Good morning. This is Monday morning, and I will be talking about cerebral palsy today. I'm going to try to get in all the pediatric disorders online so that you'll have something to go by when you study for your opportunity. And since we don't have too much time on Wednesday, we'll recap a little bit about the pediatric disorders and then we'll go from there. We'll see how it goes today. I don't have any slides per se or PowerPoints for cerebral palsy. However, I think a picture and this picture slideshow will show a whole lot more than the written word, especially in the faces and in the different types of cerebral palsy that you'll see. I don't want you to get all bogged down in the different types, which your book goes over on page 746, the 5 classifications of cerebral palsy, the dyskinetic, the spastic, ataxic, rigid, and the mixed. It's in the pathophysiology on page 747. That's not really the most important thing that you really need to focus in on is basically the care of these types of kiddos and what really is cerebral palsy. Your book defines it as a chronic, non-progressive disorder of posture and of movement. What's important is that it's chronic and it's non-progressive. So it's characterized by those difficulty in controlling the muscles because of an abnormality that's in that extrapyramidal or pyramidal motor system, such as the motor cortex, the basal ganglia, the cerebellum. And a lot of the comorbidities with it is cognitive impairment, hearing impairment, speech, visual impairment, as well as seizures. And we'll talk about seizures today as well. They're very common, but they vary from each child. So when we look at the etiology of all the cases of cerebral palsy, because it's a big umbrella of cases, you look at what can happen in utero. They can have a vascular occlusion. Sorry, I lost my slide there. Hold on just a second. Okay, there we go. So they can have a vascular occlusion in utero. There can be some cortical disorders. There can be some structural maldevelopment during gestation. They can have genetic syndromes or maybe a congenital infection. There are some natal causes, hypoxic ischemia injury at birth, and some postnatal causes are about 10% of all cases. Preterm infants vulnerable to brain damage from ventricular leukomalacia, secondary to ischemia and or severe hemorrhage in the ventricle system, meningitis, encephalitis, encephalopathy, head injury, accidental, non-accidental head injuries, symptomatic hypoglycemia, hydrocephalus, hyperbilirubinemia is another one. So they have the different classifications of cerebral palsy, and you can just kind of read those over in your book. But I think when we really look at our children as they grow, we have to make sure that we do a great growth and development. That's why they're in the pediatrician's office all the time, to look at those milestones of the patient. So the different types of CP that are mentioned in your book can correlate with their clinical presentation. And I'm just going to kind of go through these slides just so you can kind of see some of the different types of cerebral palsy. And it looks like this little guy has a lot of motor type of problems. And remember, those muscles are shortened because of the cerebral palsy, and you can kind of see it in the contractures as we'll go through these slides. And here's another. Let's see. Okay, she's having some physical therapy with this little one, and you can see that there's also some comorbid defects, some eye problems with this little girl. And that one you don't see too much. And it looks like this little guy, see his left arm, how it's contractured. That's why it's so important for them to have PT and OT, on a daily basis. Range of motion, very important. And this little guy, as you can see through the pictures, there's from very, very mild cerebral palsy to a more spastic quad type of symptoms that you'll see, those spastic quads, that all four extremities are contractured. And this is another little guy, kind of reminds us of the other little boy in the first picture. But you can see he's using his canes to help his lower body movement. This is very, very characteristic of our spastic quads. We have to really support them in different kinds of mobility devices in order to gain stability of their extremities. Because especially when they get very excited, all the extremities will become very spastic. So this is very very usual, especially like if you're going to feed the child, take the child for a walk, to gain a little bit more control over their spasticity. You'll also see that our children that have cerebral palsy are very thin. They use a lot of energy for their activities, especially if they have spastic problems. Sweet, sweet little girl with her mama. How sweet is that? You can tell that she's probably a spastic quad. And not all cerebral palsy is made alike. You can hardly tell from this picture here about this girl that's growing. These little guys. And you can see here everybody's helping in the nutritional needs of the child with cerebral palsy. Sweetness, very sweet. And of course they're like any other child. They don't want to eat. They get a lot of physical therapy, occupational therapy, speech therapy. So it's a multidisciplinary type of disorder that we really need to address. These are some of the supportive devices that they'll use to keep the body in, alignment and to aid the child with motor deficits. Here's a wonderful, wonderful picture of a mama who is taking care of her child with cerebral palsy. As you can see, a little bit more involved care with this child compared to the other children that you may have seen. Okay, so just wanted you to get some of the neat pictures of these kids. So sweet, so lovable, and many of them don't have any kind of cognitive impairment, and some may have some learning disabilities, of course, and it just depends on the type and the amount of motor disability that the child may have and what it affected in utero. Okay, so I think we'll leave it here, and we'll go over some early clinical signs of cerebral palsy, and that's the abnormal tone and limb and or trunk posture in infancy, with delay in achieving motor milestones. So the milestones are huge. They're very, very important, with or without slowing of head growth. So they're doing the head circumference on the child, and they can have that delay with or without the head circumference being delayed. They have difficulty or slow feeding, gagging, vomiting, oral motor incoordination, abnormal gait once the child is walking, and they may have asymmetric hand function before the age of 12 months. They also may have some persistence of those primitive reflexes, and there's common associated findings, including seizures, hearing impairments, visual impairments, sometimes mental retardation, sometimes not. So you can't always go by that. They may have speech and language disorders, growth disorders, of course, developmental delay. They'll have, usually they have GERD, gastroesophageal reflux, nutritional deficiencies, and it's usually due to that poor feeding, that reflux, aspiration that they may have, and they also may have some behavior and some emotional problems associated with it. Diagnosis of cerebral palsy is usually on clinical exam and history. They will do MRIs, especially when the cause hasn't been identified. Metabolic and genetic testing are not routinely required. Associated conditions such as they may do an EEG, they may do screening for any cognitive disability, any hearing, eye, vision impairments, speech and language disorders. Any of that should be evaluated by the appropriate therapies. So management, spasticity should be treated first to improve that function, to reduce the pain and provide ease in caregiving, because it's very, very difficult when your little one has that spasticity. So focal, that spasticity, can be treated with the botulinum injections, which can reduce spasticity and improve gait. They also may do some serial casting that can be done with or without the injections. For generalized spasticity, they give oral antispasmodics such as the benzodiazepines. They are used very rarely due to the drowsiness and interference with head and trunk control, but the intrathecal baclofen allows for control of spasticity through that low dose administration, and is usually very effective for lower limb spasticity. And just remember that intrathecal baclofen lowers the seizure threshold, so children may develop severe withdrawal syndrome characterized by fever, hypertension, tachycardia, agitation, hallucinations. So it may occur in situations of pump malfunction, catheter breakage, or improper filling of the pump. So make sure that you never just quickly withdraw baclofen. It's also important that one of the other management that they do is selective dorsal rhizotomies, and they'll do that through surgery, and they basically when that happens, they cut the nerve roots and by doing that, it will decrease the spasticity because we don't have the nerve intervention to that motor end plate that's causing that muscle to spasm. We have to monitor and we have to treat for scoliosis and any hip subluxation. That's important. We also have to look at their growth and nutritional problems because they can become very severe in CP, resulting in very, very poor health. We have to also monitor for any drooling because some of them have impaired swallowing or poor lip closure. So a lot of times we'll give anticholinergic medications such as Robenal or Vistaril. But we always have to watch for significant side effects with those. It's been reported that injecting Botox into the parotid glands decreases salivary flow without the side effects of the anticholinergic therapies, which is excellent. We also have to treat involuntary movements such as dystonia, and usually with levodopa is used as an initial treatment, and Artane. These are anti-Parkinson's type drugs. Chorea we can treat with the benzodiazepines such as Klonopin and Haldol. But remember, the side effects are great with those types of medications. So our complications with cerebral palsy is contractions, hip dislocation or hip subluxation, malnutrition, and scoliosis. So on our nursing assessment, we want to determine the ability to perform activities of daily living. We want to evaluate the ability to protect the airway, such as gag reflex, swallowing, assess their nutritional status, assess neuromuscular function, assess their speech, their hearing, their vision, evaluate that parent-child interaction, very, very important. Determine the parent's understanding of and the compliance with the treatment plan, and assess for any pressure sores, especially in areas of friction where they wear their splints or where they wear their braces, and assess for any presence of pain. So our nursing diagnosis is impaired physical mobility related to altered neuromuscular functioning, delayed growth and development related to the nature and extent of the disorder of cerebral palsy, interrupted family process, and risk for injury. So in our nursing interventions, we want to teach the parents to carry out appropriate exercises. We need to use splints and braces to facilitate that muscle control and improve body functioning. Make sure that they or you remove those for the recommended time. Inspect underlying skin for any redness, irritation, skin breakdown. Use the assistive devices, such as any kind of grooming tools, writing implements, utensils, handles on toothbrushes, spoons, and forks. Encourage self-dressing with some easy pull-on pants, large sweatshirts, Velcro closures, and any other loose clothing. Use play such as board games, pegboards to improve coordination. Maintain good body alignment to prevent those contractures, excellent and very important. Provide adequate rest periods. And administer or teach the parents about the side effects of medications, how to administer them, those types of things. As I said before in pediatrics, in the pediatric lecture, I think that was it seems like a long time ago now, in the summer is obtain a great history from your parents. Remember, your parents are your best teachers when it comes to their child. So make sure that you know how they are fed and what special tools they use, their sleeping patterns, their physical therapy, what they like to do to play. How do you know that the patient's or the child's in pain? How do you know what kinds of things does the child do to elicit pain? What are the psychosocial needs of the child, of the family? What are the pain assessment? What's the management? So it's all encompassing when you have a child with cerebral palsy, but it's very, very rewarding with our children, and especially working with the family and getting to know the child and how he communicates with you. If it's not verbally, then it may be through their communication, through their eyes, through tapping, maybe through, as you can see here, this picture, maybe there's a special computer that they have pictures that they can tell you what they want, what they need. And it goes through the whole gamut of being just mildly cerebral palsy to the most profound, and it's very rewarding. It's very very touching what these families all go through. But remember to treat the child as a child. He is a child before he is a disease, and I think that's most important.